We've spoken about the development and progression of cancer, and last time we spoke about the various mechanisms that might be used to screen for cancer. I want to talk now about the treatments that are typically used in managing this very common disease. There are several different ways that cancer is treated: surgery, radiation, chemotherapy, targeted therapy, biologic treatments, and there are also newer treatments, including immunotherapy and stem cell therapy. We're not going to talk at all about these newer treatments, but rather focus on the ones that are more commonly used. For each of the different types of treatments we talk about, I'm going to mention what it is specifically, why we use it, and some of the potential downsides associated with the treatment. Obviously, you all know what surgery is. Surgery can be an open wound or it can be minimally invasive, and that would be a laparoscopic type procedure. Surgery is done to remove the tumor and some adjacent healthy tissue. That healthy tissue is referred to as the margin around the tumor, and we hope that when the surgeon removes the tumor, he or she is removing some adjacent healthy tissue to ensure that the tumor has not migrated, or the cancerous cells have not migrated into the surrounding tissue. On occasion, the surgeon will also remove some regional lymph nodes. Those are neighboring or nearby lymph nodes, and this is again to ensure that the cancer cells have not disseminated into the neighboring lymph tissue. Obviously, surgery is limited to solid tumors. We cannot undergo a surgical procedure when we're talking about blood cell tumors, for example. Lymphomas and leukemias cannot be treated through surgery. There are a couple of reasons that someone might undergo surgery for cancer, and that would be the first is obvious, to remove the tumor completely. So you remove the tumor and some neighboring tissue. But on some occasions, a cancer patient would undergo surgery to debulk the tumor, in other words, to make it smaller. And in some cases, this is because we're relieving symptoms. So for example, if somebody had lung cancer, you might cut out the cancerous portion of the lung to allow for the healthy lung tissue to expand into the chest cavity, giving it more room to do that. So that could relieve some of the symptoms. In other cases, the downsizing of the tumor is done so that the effectiveness of other treatments might be better. So in other words, if we're going to have a patient with a very large tumor undergo chemotherapy, maybe we just want to get rid of the vast majority of the cancer through surgery and then subject a patient to chemotherapy or radiation therapy. The downsides associated with surgical treatment of cancer include pain and potential infection. Obviously, somebody who's undergoing surgery is going to be sedated, so there are some risks associated with that sedation. Sometimes people die from that. And of course, surgery is not a cheap option or an inexpensive option, so it's expensive. There are several different types of radiation therapy, and the most common one, the one in which you're probably most familiar, is external beam radiation. And I have an image here of the machine that is going to be emitting that radiation. An individual would have a mark placed upon him or her that would denote where the beam would be going in, and obviously a physician, a radiation oncologist, will determine the depth of that tumor in a patient, and the external beam would be set to go through a person's body to that depth so that the radiation would be hitting the tumor. There are also internal radiation therapies, and these are referred to as brachytherapy. Brachytherapy can either be permanent or cyclic. The next image shows you the first of those. Permanent brachytherapy is accomplished by implanting radioactive pellets, and these radioactive pellets are implanted and they emit radiation to the surrounding tissue. The image at the top shows you a cartoon where the implants are adjacent to the tumor and they will be emitting radiation to hopefully kill those tumor cells. The pellets themselves, or the implants, are shown on the left lower image, and what do I want to say? Some sort of machine is shown in the middle image, where each of those needles is going to have a pellet placed in it, and then those pellets are implanted in an individual. So the X-ray of those implanted pellets are shown in the right lower image, and this is obviously in the pelvic region. So this is the type of implantation that might occur in an individual who is diagnosed with prostate cancer. So that middle image is the implantation of those pellets between the scrotum and the anus. So not particularly comfortable, but once they're implanted, they stay in you forever. There are also systemic radiation treatments. These are not super common, but if somebody has, for example, thyroid cancer, that individual might be treated systemically with radioactive iodine, and that is because the iodine will go directly to the thyroid. That's the only place in our body where we use a lot of it. So the radioactive iodine would go just to the thyroid gland, even though it was administered systemically, and impact the thyroid tumor. This is an image showing the cyclic brachytherapy, that internal radiation treatment, where, and this would be treatment for breast cancer following removal of a lump by a lumpectomy, or following a biopsy. So what happens here is a needle with a port attached to it, and the port is that sort of tube with the different inlets and outlets associated with it, that is surgically implanted and left in place so that the patient can come back for radiation therapy on a regular basis, maybe daily for a period of time, or maybe weekly for a period of time, where a little radioactive pellet is placed in that tube into the breast, in this case, and left there for a certain period of time. And then the pellet is removed, but the port is left in place. And I'll let you sort of read the words as you're trying to learn about this. But this is an example of brachytherapy where the pellet is not left in permanently, but a port with a tube attached to it is left in for the duration of the treatment, which might be weeks. The purpose of radiation is to induce DNA double-strand breaks, so it's meant to break both strands of the DNA, as well as to generate things called free radicals. Free radicals damage tissue, and the ultimate purpose of damaging tissue and inducing these double-strand DNA breaks is ultimately to kill the cells. And I say ultimately because one of the downsides is that radiation treatment typically does not exert its effect immediately, but rather the cells are going to die over weeks or months. So a person cannot know whether or not radiation therapy has been effective for several weeks or months after its conclusion. Radiation therapy does cause fatigue in individuals. External beam radiation can be associated with skin irritation at the site of entry where the radiation beam is entering. There is also the possibility of what we'll call collateral damage. So if the beam is not 100% accurately hitting the tumor, it may damage nearby organs and tissues, and I've listed as several different regional collateral damages, but it just is associated with where your particular tumor happens to be. So if you have a tumor of the gums, for example, then it's possible that the radiation beam would damage local salivary glands. If you have colon cancer, then maybe nearby bowel sections might be impacted, etc. If the cells don't die, or if nearby cells don't die, then it's also possible that the DNA damage and the free radicals can induce changes in the DNA of neighboring tissues, and that can ultimately produce more cancer at a later date. So one of the downsides of radiation therapy is the development of cancer sometime down the road. There is a new type of radiation therapy that's called spot welding radiation. The second of those listed here, stereotactic ablative radiation, otherwise known as SABR radiation, is a highly focused radiation beam given for a short time. So the machine that is used in SABR is shown here, and it is radiation guided by CT. So a CAT scan will more accurately place the beam, and the beam is usually done at a higher dose of radiation, but usually for a shorter period of time. And the purpose is not to eventually kill the cells, but rather to kill the cells immediately. So this is, rather than inducing DNA damage, it's meant to ablate or get rid of the cancer cells. This is usually done for smaller tumors, those that have been detected early. The downsides associated with SABR are the same as those associated with conventional external beam radiation, because it's effectively the same thing, just more intense, guided by a different mechanism for a shorter period of time. And by shorter period of time, I mean typical radiation therapy is done for, let's say, 15 or 20 minutes once a week or once a day for a period of time. If it's once a week, it might be over the course of 6 or 8 weeks. If it's once a day, it might be over the course of 2 or 3 weeks. In this case, it's just a few days, maybe 5 days, for example, but the radiation beam is more intense. Chemotherapy is something with which, at least that word is something with which you are probably all familiar. You've all heard of chemotherapy, but chemotherapy is simply treating cancer with chemicals. That's the chemo part of it. The chemicals are generally given either intravenously, intramuscularly, intraperitoneally, which means injected into your abdominal cavity, intrathecally, which is into the cerebral spinal fluid, or sometimes the chemicals are delivered topically. It just depends upon how the best way a drug is meant to be delivered and the location of the tumor. So the purpose of chemotherapy is to eradicate or cure the cancer, or alternatively to control the cancer's growth, and in some cases to ease the symptoms. All of those are accomplished by shrinking the tumor. So on the left-hand side, we have a tumor. After a chemotherapy agent is delivered, the tumor is smaller. It is not typical for a tumor to completely go away. Sometimes you hear individuals say that their cancer is in remission, but what that really means is the cancer hasn't gone away. It's simply gone to a size that is either undetectable or a small enough size where changes in the size of the tumor as it's growing at a small enough rate that you're not detecting increase in tumor size over a period of time. The chemotherapy agents that are used, the chemicals that are used, are meant to attack cells that are rapidly dividing. So of course, tumor cells are generally rapidly dividing, but so are other cells in your body. So the chemotherapy agents are attacking all cells that are dividing at a relatively rapid rate. The chemicals that are used fall into one of four categories. They are either DNA damaging agents called alkylating agents. They are anti-metabolites, so these are chemicals that interfere with the normal metabolic reactions that rapidly dividing cells are using. They are agents that interfere with DNA replication, so they stop cells from replicating DNA normally during the cell division cycle. Or they are agents that interfere with the process of mitosis. Most of those specifically interfere with the development or function of the spindle fibers that move chromosomes around during mitosis. So all chemotherapies, all chemicals that are involved in the treatment of cancer fall into one of these four categories if they are classically chemotherapy agents. Normally, individuals are not treated with just one chemotherapy agent, but physicians do what is called combination chemotherapy, where you will have a drug or multiple drugs in each of the categories that are delivered simultaneously. And this is so you can be effective at treating the cancer. Obviously, if you've heard of chemotherapy, you've heard of the downsides of chemotherapy. There are a ton of them because all of your body cells are being exposed to these chemotherapy agents. There is potential for all of the cells in your body to be harmed by these chemicals, and those that are rapidly dividing are more likely to be harmed, and that induces fatigue because you are destroying your blood cells, nausea because you're destroying your gastrointestinal cells that are growing, potential infection, again because you're destroying your immune system, bleeding, again because you're destroying the lining cells. There are some other local effects that can occur, obviously more cancer. And then there is something that if you're treated for a long period of time with chemotherapies, you can develop resistance. And this is actually quite common where your cells develop a way to spit back out the chemotherapy drugs that are used to treat it. And it's a bummer because you can't defeat that. Targeted therapy is kind of like chemotherapy, except for the molecules that are using are chemicals that are meant to target specifically intracellular proteins that are involved in regulating cell division. So I've listed that here as small molecules directed to intracellular messengers. Those intracellular messengers, again, are usually proteins inside of the cell that are involved in regulating the cell's division cycle. Alternatively, the targets are things on the surface of cells. So targeted therapy can be an antibody that is directed to one of these cell surface proteins, and those antibodies bind to these cell surface proteins to either flag the cells for degradation by the immune system, or sometimes to deliver chemicals specifically to the cancer cells. So the advantage of targeted therapy over general chemotherapy is that these targeted molecules are meant to attack just the cancer cells, selective and specific. So not rapidly dividing cells in general, but only targeting the cancer cells. So it is specific. Oftentimes, however, these targeted therapies are not available in pill form. They've got to be delivered via infusion. They are expensive. There are not many side effects, but you can develop resistance to these targeted therapies. In other words, you might take this Gleevec chemical or be treated with this Gleevec chemical, but ultimately the cancer may come back if it develops resistance to Gleevec. Okay, and finally, biologic treatments are treatments that don't specifically target the cancer cells, but rather target other biologic processes that help the cancer cells grow. So a few of the potential targets of these biologic treatments include targeting cell adhesion or cell migration, and those might be involved in the metastatic process, so you can inhibit metastasis with biologic treatments. Biologic treatments presume that if you can stop this process, you can stop tumor growth or tumor progression or tumor spread, cancer spread. So again, it's not targeting the cancer cells specifically, but rather targeting biologic processes that help tumor cells sort of tangentially. I say not many or few side effects, but it depends upon which biologic target you are addressing. So, for example, on the lower part of this image, you see angiogenesis as one of the potential targets of biologic treatment. Angiogenesis is a fancy word for saying blood vessel development. Tumors need blood vessels to grow into them, and those blood vessels that grow into tumors are there to help supply the tumors with all of the nutrients that the rapidly dividing cells need, but they also take away the waste products. And if you can stop the development of blood vessels into a tumor, you can often limit the size of the tumor. However, it's true that we need to grow new blood vessels if we wound ourselves. So if we injure ourselves, we need to repair that tissue, and that repair necessitates the regeneration of blood vessels. So if we take a biologic treatment for cancer that inhibits angiogenesis, one of the downsides of that is going to be impaired wound healing. Often, biologic treatments must be taken for the rest of your life because the tumor is still there. You're just inhibiting its ability to progress. And because you're taking these treatments for the rest of your life, it's not inexpensive to do that. So hopefully this PowerPoint provides you with a little bit of I guess, everyday knowledge of some of the treatments associated with the development and progression of cancer. And this is the end of our discussion on cancer. So we only have one more PowerPoint left, and that is on evolution. I will, oh, I forgot here. There's one more slide. And this is just a little bit of discussion on the curing of cancer. I am not going to play this, but there is a video that you can watch on YouTube. It's about 5 minutes long, and it will talk about our potential to not inhibit tumor growth, but rather to cure the disease altogether. And after watching the video, I'll leave it to you to decide whether you think that developing a cure for cancer is a possibility in your lifetime. Like I said, this ends our discussion on cancer, and we will transition to evolution, although I will make some ties back to cancer, because the progression of cancer actually is an evolutionary process.